accreditation. We're looking at accreditation of the internship program at the hospital, accreditation hopefully of the lab, accreditation of the hospital as an entity, a healthcare entity, and even smaller but as important certifications as the Baby Friendly certification, something we had before and we need to once again be a holder of. We would also be looking at the strengthening of operating systems. Again, things like preventative maintenance. As Dr. James mentioned, a lot of people, their concern or their dissatisfaction is not necessarily with the actual clinical care, but an untidy and unsightly plant. So cleaning schedules. And we also cannot forget the outstanding acts that are still hopefully to be passed since they're in the final stages, the Medical Act, the nursing pharmacy, the allied workers, because all of those will help to guide professional conduct and behavior, and at the end of the day should result in better care for our patients.
Sure, thank you. Dr. James, you want to weigh in on this? Or
well,
she's covered it. She's given a comprehensive response to this question. Thank you. Now, I have cited before the urgency to arrest the high incidence of chronic non-communicable diseases here, which I think must start at the primary healthcare level. What systems can be developed though, at the level of the management to address these concerns?
Okay, so this is again very important question. And let's start with some data. In any given week, about 3 days, there is an observation unit in the accident and emergency department. And it is usually full of patients with NCDs, chronic non-communicable diseases, hypertension, diabetes, the cancers. And on our medical wards, Glover and Emory ward, most days there are over 90 to 100 and even over 100% occupancy rates. So obviously there are problems. These are the patients who come and spend the longest time at the hospital for special diet, exercises, not smoking, alcohol in reasonable quantities. And we can do as much as we can as healthcare professionals, but if at some point persons don't say, I want to be healthy, we've essentially lost the war even before we started. From the healthcare system point of view though, we need to put some focus on our screening programs. When we look, for example, at cancers, and many cancers, because of where the science is right now, we have specific tests and investigations that we can do that can either predict you're going to develop one or diagnose it very early at a stage where things can be done. And so we really need to focus on those preventative and screening programs. And that is obviously very much a primary healthcare function. So we've opened the bottle, primary healthcare. That's where it's all starts in terms of your education, your prevention, your health promotion strategies. And since we are looking at secondary tertiary care at the hospital, we really, as a country, I believe, should also use this opportunity to review primary health care. Even if we do perfectly at the hospital, because it is not a separate system, it's really a continuum of care. If primary health care is not working, secondary health care will be burdened with a number of things that really we shouldn't be. So we need to really spend some time looking at primary health care. We need to look at how it is practiced. We need to look at training for the doctors and the nurses. We need to look at things like who we engage, how we compensate them, and what we hold them accountable for. Pretty much the same things that we're talking about at the hospital, we need to also begin to look at those factors at the primary health care.
Well, I agree with you on the primary health care issue. I've been an advocate of this for many years. No, we're making strides with the provision of healthcare at the main hospital. For example, Recently, we opened the cardiology department, a milestone for the country's healthcare system. What other major improvements can we expect in the provision of healthcare moving forward?
So I must say these are very exciting times for the healthcare system in Dominica. As a practicing physician, this is really a very unique time to be a doctor, nurse, somebody within the system. First thing, we've had over the last year or two a number of young Dominicans who've returned with specializations, specifically cardiology, ear, nose, and throat, gastroenterology, urology, oncology, ophthalmology. And some of those areas, those are the first time we've had any persons who are locals in these areas. So this is obviously the first important step. There are a number of ongoing projects. Just yesterday, we signed the Memorandum of Understanding with the World Pediatric Project. And for those who may not know, the WPP provides care to our children population in a number of different areas. Just on Friday, for the first time ever in Dominica, we had a screening clinic for scoliosis. That's for children with abnormal curvature of the spine. Persons may have also heard about a week ago about the artificial intelligence project that is going on in the eye department, where we essentially are using technology to determine or to help us with provision of care in patients with diabetic retinopathy or to diagnose diabetic retinopathy. And diabetic retinopathy is important because it's a major cause of blindness in persons who have diabetes. We are also looking forward to significant improvements in our radiology department. The MRI should hopefully be commissioned very soon. And we are also hoping to employ personnel who will help us to improve or add to the services that we can get from the CT scan machine. In addition, training has already started on the use of the HIFU machine, and by my last check, we're the only country in the Eastern Caribbean with such a machine, so the possibilities are endless. We want to very much develop the eye department as a center of excellence, where we'll be able to bring in specialists and subspecialists to provide care not just to our local patients, but probably for the first time, we will have persons who will be coming into Dominica to seek care. We're all accustomed with us going outside, but hopefully that can be reversed. And eyes are really well suited because they have their own separate unit, they have their own theater, and so the physical setup is really there. And we do have personnel right now for us to really make this dream a reality. We are also in the process of finalizing an MOU with the Brenda Strafford Foundation, and that would again help to enhance our ophthalmology, our eye care. We are also in advanced discussions with the University of the West Indies, Kiville campus, on a number of issues. One, to assist with eye care, but more widely to use Dominica as a site for certain portions of their postgraduate program, obviously in certain disciplines. And that would be a major success story for us, because we would then be essentially bringing in persons who are trained, specialized, or almost at the end of their training to provide care. It just really raises the bar of healthcare provision. We are also looking at just MOUs with other healthcare facilities and healthcare organizations so that we hopefully can develop exchanges, visiting relationships, visiting specialists, which all of which will obviously enhance healthcare. So there are a number of irons in the fire right now. Okay?
Sure. Now, I mean, you mentioned eye care and the HIFU machine, but the concern of the public, which has been a perennial one, of our inability to perform some major procedures here And of course, we've had to airlift people, or citizens have had to seek medical attention or medical intervention overseas. Do we anticipate the new structure, the new administrative structure, and all of these changes that we're making in respect to hospital management? Will we see a change in this, where we'll be able to have more of those services offered here in Dominica as opposed to our citizens going out?
Well, PM, what we're trying to do is to guard against trying to bring in too much subspecialist. We have to define the package of services that is both affordable and sustainable. Dr. Blanc raised earlier on a number of areas of subspecialization that we have at some countries, even in the region, with far more resources than Dominica do not now have. And we have 2 urologists on staff. We have 3 ophthalmologists. We have 3 oncologists. We have 2 gastroenterologists. That is a fairly comprehensive package. So our view is that let us provide those services well. Let us develop them and provide them well. And in other words, the greater good for many, all right? And the other services, we could find other ways of addressing them. Those could be addressed by bringing in specialists to operate at our hospital, and or where necessary, we transfer overseas. We now have an 8-bedded ICU, so we could stabilize patients and transfer overseas. The government spent last year $2.4 million to transfer patients requiring hospitalization elsewhere. And it is mainly for cardiothoracic surgery, neurosurgery, and vascular surgery. So when you look at it, we actually have a decent package of secondary services. The problem is that we need to develop it and sustain it. If you bring a neurosurgeon here to operate in Dominica, let's suppose you were to get a neurosurgeon. A neurosurgeon doing perhaps 1 procedure every 2 months, in a very short time he'll de-skill. So that you have to guard yourself against trying to bring too much super specialists, because we would do perhaps more harm to our patients, because when the time comes for him to operate, he's lost touch. And surgeons must be doing work to be able to function well. But I am satisfied that based on what we have on the ground now, we could provide at least 95% of the health problems that the country has. And let us find a different way to address the remaining 5%. Through visitorships, to observerships, to visiting specialists in country. And we have the ability now to stabilize patients. We have 8-bedded ICU, which is more capacity than we really require right now. Take, for example, an area as ophthalmology. This is the only country that has a dedicated eye surgery. No other country has it. So we have a situation where our ophthalmologists could operate 5 days a week. We've already had early discussions with UWI and some of the specialists, within the region, where the consideration is to batch cases, bring them to Dominica, and operate in our theaters. So, in short measure, what I'm saying is that the infrastructure that the government has invested in terms of both primary care and hospital is more than enough to satisfy the resident needs. We just have to develop the capacity and so that we could leverage that for the benefit of patients.
Excellent.
I think so.
I agree entirely on this. Now, we're aware of various complaints about the operations at the hospital in relation to service delivery, and you alluded to this, both of you,
Yes.
earlier on. How will the new administrative structure truly impact people and the way service is delivered at the hospital? How is the common man now expected to benefit directly from the changes we're making? Because we have gone to the Parliament in response to the concerns of the public.
Yes.
Now that we've gone to Parliament, the legislation is in place. The board will be appointed on the 1st of August 2021. How is the common man expected to benefit from all of these changes, though?
Yeah. Well, as we said earlier on, the move really is the shift in focus from a doctor-centric hospital to a patient-centric hospital. That's the first order of business. And in so doing, patients must have a say in the care provided to them. Right now, it doesn't exist. So that is perhaps the most fundamental shift. We want to empower patients. If you have concerns, complaints, or commendations, we call it the 3 C's. We have a quality department that is independent. You can go to them and lodge your complaints. You don't have to fear that your future care will be compromised. There's no need to fear it at all. So we want to empower our patients and our public to feel comfortable that they must be able to have recourse. The view that the hospital is a doctor's hospital is a myth that we have to change. This is the taxpayers of the country facility. So what we're saying is that the ordinary man must have an equal chance of getting good access and good quality care as those of us who have insurance or deep pockets to pay for private care. That is a myth we have to change, because we've seen evidence where those who have ability to pay can perhaps jump ahead of the queue, ahead of someone who doesn't have access to financing. This is something we have to address. We begin to put structures in place to make sure that there's equity and fairness in terms of everyone, whether you're paying or you're not paying, to have an equal chance of access to care at the hospital.
Now, let us talk about the issue of the speed and the efficiency of service. One of the main complaints of the Dominican public is how long it takes to get served at the accident and emergency department. People say nurses are not available or doctors are not available. The doctors who on call have been called but have not shown up, and an hour passed, 2 hours passed, 3 hours passed, 4 hours passed, 10 hours passed, 20 hours passed.
Yes.
You know, there was, and also the delay in getting admitted. You know, the doctor at the A&E says you have to be admitted on the ward, and it takes you a very long while to get on the ward. Now, there's one thing if there are no beds, but if there are beds,
yes.
you know, I mean, you spoke and quite rightly so, both of you, that people don't complain about the end result. But the process is also very important.
That's true.
You know,
yes.
the process might even make you get better quicker,
Yes.
if it's efficient and speedy. So, have we started to address these things, or we have a system in place, a plan in place, to address this perennial complaint of the public?
You want to take?
Okay. So first of all, the public has to help us, especially with regards to the emergency department, accident and emergency. Maybe we need to do a little bit more re-educating, but up to 60% of persons who come into A&E really are not through emergencies. They ideally should be seen at the primary healthcare system, at the different health centers. However, having said that, we do recognize that if a person presents for care, care has to be given. And so one of the new initiatives that we want to set up, or we're in the process of setting up, is a minor case unit, where essentially patients who are not very sick, we can, for want of a better word, fast track them so that they're seen, whatever is done for them, if any diagnostics are needed, those are done quickly, and they're able to be discharged without spending a significant amount of time at the unit. We also have to strengthen our triaging systems, and we're talking specifically again at the A&E, where persons are seen really not so much as a first come, first serve, because that's not how an accident and emergency department should really function. But the true emergencies are obviously given priorities. Now, again, we probably need to do a little bit of educating of the public so that persons know that if there's a car accident, somebody is having a heart attack, that those persons really have to be given priority over somebody who probably, I don't know, Busghetto, something that is simple and not life-threatening. In addition, we are looking at and setting protocols that we obviously will be monitoring and enforcing in terms of the response time. Response time to patients who are referred from casualty or A&E to the wards, the times at which the ward doctors should see them by, and also response times if there's an issue on the ward and the nurse calls in the doctors. We are also in the process of reorganizing accommodations, especially for the junior staff, so that they're brought essentially on compound, which means that when they're on call, they will be very close, and so response times will be significantly shorter. We have taken to heart as well the issue of the overcrowding, and we have put in place a surge policy. So there's a mechanism in place. Obviously, it's not foolproof, but if the A&E becomes very full, that there are a few things that we do to try to decompress the wards so that we can clear A&E and make it essentially available for when true emergencies come in. If a patient is admitted to the ward, they really should be on the ward and not in A&E. We are also looking at the issue of staffing in theatre, because you didn't bring it up, but we know that that is an area of concern where the theatre staff on many occasions have to actually be brought in. So we really need to move from on-call to an on-duty. Right, so they are on compound. It will take a little work because we very likely will have to increase or reorganize the staff. There are discussions as to adding scrub techs to the staffing, and all of that will help with the response times and having those critical persons on compound. Lab, radiology staff, again, we're working with those areas, and even in radiology, for example, while on a weekday they would have ended at 4 o'clock, we have now implemented a system where there's somebody on the radiology tech is on compound up to midnight, and hopefully we will evolve as we progress into a 24-hour presence. So we're taking to heart those concerns because they do speak to clinical outcome, clinical care. We ask the public to be a little bit patient, to work with us, but we've heard their cry, and we're working on it.
So Dr. Plus says that improvements are coming, and they're on their way, and there's a strategy to addressing the perennial concerns of the general public. So we'll take your word for that. Now, Dr. James, what administrative changes have been made since you took up your post, and what other changes in administration can we expect to see now that the legislation has passed?
Well, we've implemented a number of changes to improve the patient care experience. So, for instance, we've now centralized cashiering services, appointments and admissions at the main entrance to the hospital. So essentially we've created a sort of one-stop shop. You come for admissions, you can sit in a convenient office, and you can transact for your admissions. And these for elective admissions. Because what was happening is it was just really untenable. So that has been an experience where patients have really lauded that initiative. We've sort of move our housekeeping services to improve the environment of care towards a sort of 24-hour schedule. So you'd observe the facilities are a lot tidier. We actually put on a 7 p.m. to 7 a.m. shift, because I felt that, when the public comes out for service early in the morning, they must meet bathrooms clean, the floors clean, corridors clean, elevators clean. And so that is a shift we've put on. We put on an additional shift in terms of the manufacture of oxygen. And for the last 4 months, we haven't outsourced a bottle of oxygen. That has, in a sense, made, the plant a lot more robust. We're not dismissing the private sector, but in a sense, we've become self-sufficient now in the production of oxygen. Key to it is, of course, maintaining the plant. We put an inventory management system in place to know when wards are short of oxygen so we could top up. That is a major, major change. I mean, we've reduced the outsourcing bill by over 80% over the last 4 months, simply because we have now put better management arrangements in place to reduce the outsourcing. To come, we're going to change the organizational structure. We have to change the structure to align it to the business processes that have been delegated to the board. And so very shortly, as you may have seen, we've advertised for Chief Operating Officer, Director of Finance and Budget, a Human Resource Manager. All of that is ready to strengthen the governance of the institution. We've established an engineering department for the first time to make sure that the plant we could guarantee uptime of the plant. We will have anything close to 3,000 pieces of medical and non-medical equipment. And therefore, we have to put in place a good engineering department, one that is going to, one aspect is going to address plant, and the area is going to address biomedical engineering. We seek to regularize appointments of staff. That has been a very, very sore point with a lot of staff, particularly nursing staff. It's a sore point for me because, you can't ask staff to perform at 100% when the tenure on tenure is very tenuous. So we're seeking to regularize that. And so I really want to commend the government for this National Employment Program. I've seen programs of it elsewhere, but at the hospital, we have about 90 NEP staff that transcends major areas across the hospital that provide excellent service. Without them, I'm not sure how we're going to survive. We really feel passionate about regularizing their status, all right, in this financial year, because many of them, arguably so, perhaps perform much better than some of the appointed staff. And I really want to take my hats off to them. They perform well. And so part of our budget programming is to regularize the status of these National Employment Program interns. Some who haven't worked very well, we send them back to the program. But we have a core that provides services in central sterilization, housekeeping, the orderlies, operating theaters. These are excellent workers. And so we're very, very happy for that support for us.
So about 70 NEP staff will now graduate to permanent employment, and that's one of the objectives of the NEP program. It's so we're happy to hear that now. Now we're nearing completion of the Margaret Hospital, and the hospital authority obviously will have oversight over this hospital as well. How will your mandate, though, in respect to the hospital authority, extend to the management of the Margaret Hospital? I want you to explain this to the public, because we have to let the public know that the hospital authority is not only for the Domingo China Infection Hospital, but all hospitals across Domingo.
Yes, the bill itself speaks to hospitals, which includes Dominica China Friendship Hospital, Marigot Hospital, and the Portsmouth Hospital. The Marigot Hospital is about 95% completed. This is, again, state-of-the-art facility. I have not seen any facility like that across the region where in one facility you have an ambulatory center that opens, let's say, from 8:30 to 4:30, and then there's the inpatient side that provides inpatient services and accident emergency services. The facility is 50 beds, 2 operating theaters, 6 ICUs, 4 recovery beds. It makes provision for 2 dental chairs, 2 dialysis units, dispensing and laboratory investigations, 3 delivery suites. I'm sure Dr. Blind is very happy about it, but there are 3 delivery suites there, and a full service accident and emergency department with imaging studies and ultrasound. It is our intention to not heighten expectations of the public beyond what we could deliver. So our approach is to have a phased opening of the hospital. Phase 1 will see what I will call the ambulatory center side kicking in. We will have dispensing, we'll have laboratory investigations, we will have dental services, we will have dialysis services. Indeed, what we intend to do is patients who live in the north and northeast part of the island, we would have them dialyze at Marigot Hospital to improve access. So what it does, it decompresses activity at the hospital. So that is the first phase of the reopening of it. We intend to also have 2 GP clinics in that phase 1. It is our view that we would adopt the protocols from the Ministry of Health for the NCDs and really set it up as a good model of what primary care could be. Lessons learned, we could then replicate that in a number of our health and wellness centers across the country. It is our intention to bring good family medicine practitioners in who will use the protocols established by the Ministry of Health to manage the diabetics, the hypertensive, and really set it up as a good center of excellence. Phase 2 would see what I refer to as the trauma center and stabilization unit. Here is where the accident and emergency department will be phased in to manage trauma and stabilize patients and prepare them for a good condition for transfer to the Dominica Triana Friendship Hospital for continuity of care. And the final phase, once we get all the doctors and nurses on board, is the inpatient care. All right, so our approach is really to phase it in until such time that we get to phase 3. We're pretty much excited about it because it could create for us a difference in terms of that seamless movement between primary and secondary care. You know, when the entire facility is completed. As I said, there are no facility I know of in the region that has in its infrastructure that combination of ambulatory care and inpatient care. Usually you would find it, a health center annex it, but in this one facility, you could essentially open half of it 8:30, close it at 4:30, and the rest of the facility is mainly for inpatient care. So this is what our plan is for the Marigot Hospital. We're working very closely with the Ministry of Health in the identification of the resources. Currently, we are establishing our protocols. To make sure that once we commission the facility, we're ready to go. Dr. Blair said to me, the intention is to also have specialist clinics. We're going to bring specialist clinics to the center on selected days. Urology, gastroenterology, again, as she's raised earlier on, to raise the bar with respect to our screening programs. So this facility is going to be a model that we believe that will be the fillip for driving the changes that we expect to see in primary health care and certainly in terms of inpatient care as well.
Excellent. Now, the new hospital authority is expected to increase accountability and transparency in the administration of healthcare at our various hospitals. Now, Dr. James, what measures have been implemented thus far to facilitate the expected increase in accountability?
Yeah. Well, we've worked with all categories of staff over the last 6 months in sharing with them what would be new and different under the authority. It could no longer be business as usual. Everyone is going to have to be accountable, from the board right down to support staff. So a lot of conversations have taken place with staff to explain what the environment will look like under a new governance arrangement. We actually tested it by establishing what I refer to as a quick wins program over the last 6 months, where we develop programs across every single area, clinical and non-clinical area, with performance metrics. I refer to it as really boot camp, because it is really almost observing how staff respond to being accountable for a set of programs. That will be really a major change for us, but it is something that we have worked on for over the last 6 months. They need to establish good inventory practices. I mentioned that earlier on with respect to the manufacture of oxygen and making sure that we look at minimum quantities across all the care settings, so we don't have out of stock situation happening. Our material management processes is going to have to be strengthened as well, to make sure that we could maintain the uptime or upkeep of the plant, and sustain operations as well.
Excellent. Now, Dr. Blah, how are the staff at the main hospital adjusting to the changes in administration at the Dominica China Friendship Hospital?
All right, so I believe the strength of the transition has been the process of consultation. And the interim board started the process very well in terms of engaging the staff. And Dr. James has done an excellent job of continuing that process. And I think I am very fair in saying that the staff is excited and they are filled with anticipation. The hope is obviously that together we can improve healthcare. They would like to see the public having a better view of the hospital.
But Dr. Blah, but isn't that, isn't the view of the hospital a reflection of how the staff though view their responsibility? If people are criticizing the hospital and none of you come in defense or to provide clarity to the public on what really is happening at the hospital.
Yeah.
You certainly have a point, sir. You certainly have a point. And all of this really has to be part of the transformation. Because as you would have heard us say, when you look at outcomes are really not that bad as, if you were to just listen in the general public. And unfortunately, sometimes even staff bash the institution. Yeah. And so we really, as part of the process, we'll have to engage in education to the public, as well as to kind of sell ourselves, to really share with the public a lot of the good work that goes on very, very quietly at the hospital. But going back to your original question, I think generally the staff are actually quite excited. They see the potential and the possibilities with the changing governance.
It's a public service problem where public servants don't feel motivated to defend their work and to defend what they're doing. The reality is, I agree with you entirely, that there's a lot more good that's taking place at the hospital than bad. But we are a society, we like to highlight the negatives. And you're right, there's sometimes people who are employed there, and some people who have the responsibility to address the issues are at the forefront of criticizing. So, and that places questions the integrity of the system and what we're doing, and then people will focus on the good. Because you have a lot of wonderful doctors and nurses and support staff at the hospital.
Excellent.
That you may not find anywhere else in the world.
It's very true.
And these people are not. We're not getting the dues because we like to focus on negatives. But we're hoping that we can at some point
begin to address it.
Begin to address those things now. Now, speaking about staff now, do we have plans for the professional development of the hospital personnel, all in effort, to bring them up to the levels and to give them the additional skills, but also to further the objectives of the efficient and quality delivery of services. So. Yeah.
Well, luckily for us, we have the Dominica State College. We've had, I've had extensive discussion with the Dean of Nursing Services and the Hospitality Institute. And they have already designed for us a number of programs for rollout, which will seek to build our capacity. So for instance, we have a credential program for orderlies. Orderlies must not see themselves as just transporting patients. There are a lot more that they can do. So the program would look at empowering orderlies to be part of a turn team for patients who are predisposed to ulcers. They should be able to set up IVs. They should be able to set up ECGs. They should be able to use a defibrillator. So we've designed a comprehensive program to raise the bar with respect to the quality of care, well, the service that the orderlies provide. We've also discussed with them developing what is referred to as Scrub Tech program, so we could remove nurses from the actual operating room and replace them with a low-level resource without compromising quality. They've designed that for us as well. We've asked them to look at customer service training. And so we are leveraging the resident capacity of the State College towards helping build capacity at the hospital. Okay. We actually work in a very creative model, because in areas where they're short on faculty, we would provide some of the faculty for the college to make sure that we could get it going. So yes, the building capacity is very important. We're going to be setting service quality standards across all areas. We can't manage something that we can't measure. And so setting service quality standards for housekeeping and for doctors as well is very important for us. So that is what is going to drive the whole quality ethos and bring us to a level of acceptable quality based on international standards.
Excellent. Now, one of the objectives of the Act is to adopt telehealth solutions as a major transformation technology for improving access to the services. How do we intend to incorporate technological advances into the administration of the hospital?
Yeah. It's a good question. Dr. Blanc outlined earlier on the artificial intelligence project that we have with London School of Hygiene and Tropical Medicine. This is groundbreaking. There's no other country in the region that is looking at using artificial intelligence as a way of diagnosing diabetic retinopathy. And I really want to publicly commend Dr. Shillingford Ricketts and Nanda Matthew, who really have worked hard on this project with the school. We had a successful completion of it 2 weeks ago. Now, what that will do for Dominica, when that project is validated, it means that artificial intelligence can now diagnose diabetic retinopathy. So what we can now do is train up nurses at the district level, dilate the eyes, take the fundus photo of the eye, and put the study in the software. And the software would say yes or no if you have diabetic retinopathy. So here's a situation where we're using technology to expand access to diagnostic investigation. But that apart, we are part of a World Bank project as part of the digital transformation product. 8.5 million US has been committed to the public health system. This is a major transformation for us, because with that project, it opens up opportunities for telemedicine solution. It opens up opportunities for patients' record to be located in one spot through an electronic medical record. It improves the efficiency of our system. No longer will we have to print reports, darkroom operations for imaging studies. Those could be sent electronically. But perhaps more important, and it is linked to the patient-centered care we spoke to, it opens up e-citizen by providing citizens with a secure portal that they could log into it with the proper credentials, have access to the health information, book appointments, cancel appointments, pay bills online. I mean, those are exciting times. It also allows for the seamless movement of patients between the hospital and primary care. So that when we treat a patient at the hospital, it is not a different patient when they go to the primary care level, and vice versa. Once you get to the primary care level with your unique identifier, the primary care doc will be able to see the episode of care provided to you at the hospital and allow for better continuity of care. So this ICT piece is really, again, yet another transformational piece that will certainly create a more integrated public health system for the country. Our vision is to have the country as a whole, but more specifically, the Hospitals Authority established as the first digital hospital in the region. This is an opportunity that we have, and I don't think it is a esoteric dream. It is as real as we believe it is. If we're able to get this project rolled out over the next 3 to 4 years, we could actually transform the entire public health system and make it a truly digital hospital between the primary care and the hospitals.
Sure.
So.
Thank you very much. Now, as we move forward with new and improved approaches to the delivery of healthcare, what can the population expect to unfold in the next 5 to 10 years? And what is the general outlook for healthcare in Dominica?
Well, I would say we will continue to develop the health systems around an integrated primary healthcare system. We shouldn't lose sight that the primary healthcare system is a fundamental approach that we're going to use for any transformation, albeit that we're looking at hospitals as one piece of it. We'll continue to develop our patient-centered model. We really have to shift that balance from a doctor-centric hospital to a patient-centric hospital. We will guarantee the public that the entire hospital or the system will be properly credentialed by an international organization. We expect within the next 3 years, our lab will be fully certified. We expect to receive the baby-friendly recertification towards the end of this year. And it's our intention to also move towards hospital-wide accreditation. Dr. Blah has already started an initiative on having the hospital credential as a teaching hospital for interns. We expect that application to go forward in the next month or so. And once that application goes forward and the hospital is credentialed, we could have interns coming from outside the region to intern at the hospital, which is really important for us. We intend to improve the overall performance and management of hospitals in a general sense so that patients could have what I refer to as a better care experience, both in terms of quality of care and care that is provided in a safe environment. And finally, we really want to create a new vision, a vision that says we're getting better with you, the public, in mind. Getting better with you, the public, in mind. And all of that really fits nicely into the patient-centered care model.
Thank you very much. Well said. Dr. Blah, you want to weigh in on this?
Well, it's essentially to support what Dr. James has already put forward. We've mentioned a number of times all of the specific projects and programs. I would just want to add the discussions that we're having and hope to have to develop the more formal MOUs with the various institutions, because that is going to be a key part, because it will help in human resource development as well as improvement in clinical services. But what I would want to really use this opportunity, sir, is to tell the public that we need them to move forward. We cannot do this on our own, okay? And it is really for the benefit of all of us. At any point in time, any of us could become a user of the hospital. We could be walking in town and just end up at the hospital. And there are a number of areas where we've spoken about patient public education. This has to be a new partnership between the hospital and the public. Again, I have to say we cannot do this alone. And, you know, in a sense, if there's nothing else that they take away from this tonight, is that the others are specifics, but we need the support of the public moving forward.
Yes.
Now, before we move forward, though, I want us to clarify and ensure that the issue of mental health is central to all of what we were talking about when we talk about the new management structure and the issues at the hospitals, correct? Dr. James?
Go ahead. Well, all I wanted to say, it obviously has to be part of it.
Yes.
When we define health, mental health is obviously a critical part. So the And it's the holistic approach to mental health. We're not just talking about admission at the psychiatric unit. And we've had, I know Dr. James has had specific discussions with the staff and the mental health department in terms of their roles, how they're going to be incorporated and be brought on board, with the other clinical areas. Doctor can probably add a little more to that.
Well, I mean, we respect there's a Mental Health Act, and so there are provisions there that provides guidance to how the act is to be executed, but doesn't take away from the fact that mental health is essentially a medical service. The same performance metrics that we're speaking to for hospitals, the acute psychiatric unit will be required to have their metrics submitted so we could evaluate the performance of it, levels of readmission rates, to what extent patients who are discharged are integrated back into the community, etc. So it is just really a specialized area of care, but it doesn't absolve them from being part of our overall performance management system within the umbrella of the hospital's authority.
Okay, excellent.
Yeah.
Well, thank you very much for your time. I believe it is very useful information, and I'm sure the public is appreciative of this. And rest assured, you have my continued support.
Thank you, sir.
Both my capacity as Prime Minister and Minister of Finance. Health has always been a top priority for myself personally, and of course for the government, and that will continue in the foreseeable future. I want to remind us that we are still in hurricane season. We need to take heed of the actions that we need to consider, take control of eliminating the hazards that we have, of minimizing the hazards, but also preparing ourselves. This hurricane season, it has been predicted is going to be very active. We have no control over them, but we have control over our preparation. And so let us focus on our preparation. Also, yes, we've managed COVID-19 very well. Thank God for that, and thanks to all of those persons who are involved in the management. But we must not take anything for granted. We must, we see what's happening in our sister countries. Just one case, it's one case you need, one case that can turn the tables. So yes, while we managed it very well, we also have to be cautious and careful about how we go about this. And therefore, we need to continue to recognize the guidelines provided by the Ministry of Health, and very importantly, for us to get vaccinated. It's absolutely important for us to get vaccinated as an additional armor in our defense against COVID-19. And of course, with these new variants that we have that are now present in the Caribbean, we just do not know. And so I'm urging us to not let our guard down, believing that COVID-19 is over. From where I sit as a village politician, I believe COVID-19 is going to be like tuberculosis, among us. It will be there, and it's not going to go away. And so we have to prepare ourselves for this new reality. And the question is, what can we do to mitigate against COVID-19? And the Ministry of Health has, in fact, assisted us with this. Yesterday, I visited the Cathedral Falls in Loda. Wonderful falls. I would urge you to visit as well. And you could also book your broth. I say broth where I'm from, with Patricia in Loda. I had one of the best broths I've had done by Patricia in Loda, and also some of the best barbecue you can find anywhere in the Caribbean. So from the falls, well, when you go into the falls, you can book your broth or you can call in advance. And certainly by the time you get back, it's cold, it's chilly up there, but the broth and the local coffee. She made coffee, Dominican coffee, and it was well done. Excellent service. So I would urge all of you to really partake in what she has to offer in Loda. Let us go forth and serve our God and our country. This is our country to build. Let us be constructive in our criticism. Let us be positive in our attitudes. And we will certainly see the improvements that we're all yearning for, the development that we're all yearning for. It's easy to complain, but complaining is not going to solve problems. What's going to solve problems? By people working together, in unity to address issues which confront us. So may God bless our country. I want to thank again Dr. Blah and also Dr. James. Dr. Blah has demonstrated a commitment to our country, being here, working with us in the health system for so many years. Young person making a contribution in a huge way, and we're grateful for this. And of course, we have our brother from Trinidad and Barbados. We're all part of one country, really, the Caribbean.
That's correct.
And we are grateful that you have decided to share with us your experience and your expertise as we navigate through the issues. We are confident that we will be successful in navigating those issues, guided with your experience and your vast knowledge in hospital administration. So you have my fullest support in your mission and that of the hospital authority. May God bless our country. As Dr. Blah and Dr. James have said, this has to be a team effort. This is every one of us. The public seeking care at the hospital, the doctors, the nurses, and all the support staff, we all have to work together. And we have to help each other better understand what each of us are going through. And I think if we have an appreciation, then there'll be no complaints at the hospital, right? We look forward to that day. Yes. Thank you very much, and God bless you.
Thank you.
I did not imagine that the prayers of my country would have been answered so swiftly.
Vaccine. Under COVID pressure in we country, mentally, socially, economically. Look, we get a blessing rather quickly to bring us back to some kind of normalcy. Yes, you over 18, take the vaccine. To protect your family, take the vaccine. To safeguard the elderly, take the vaccine. To bring back with festivals, take the vaccine. Take the vaccine, take the vaccine. Need it. Take the vaccine, take the vaccine. Need it.
This is a message from Tasha P. and the Health Promotion Unit of the Ministry of Health, Dominica.
We are in the hurricane season. Here are some tips to keep your families and communities safe. Before a hurricane, ensure that you know your emergency shelters. Contact the Office of Disaster Management for information on shelters closest to you. Have disaster supplies on hand, non-perishable canned food and water, portable battery-operated radios, flashlights and extra batteries, essential medicines, first aid kits, cash and bank cards. In the home, protect your windows. A low-cost approach is to put up plywood panels. Trim branches away from your home and cut all dead or weak branches on any trees on your property. Check into your home and auto insurance. Confirm that policies are valid and coverage is appropriate. Make arrangements for pets and livestock. Develop an emergency communication plan. Make sure that all family members know what to do. Teach family members how and when to turn off gas, electricity, and water. During a hurricane watch, listen to the radio or television for hurricane progress reports. Avoid open flames such as candles and kerosene lamps as a source of light. If power is lost, turn off major appliances to reduce power surge when electricity is restored. Store drinking water in clean jugs, bottles, and cooking utensils. During a hurricane warning, if you need to evacuate your home, lock up and go to the nearest shelter. Take blankets or sleeping bags to the shelter. Listen constantly to a radio or television for official instructions. Store valuables and personal papers in a waterproof container on the highest level of your home. Stay inside, away from windows and glass doors.